Let me now move to the next presentation. My good friend and also co-director, Dr. Ehrin Armstrong, is going to show a tibial complication. And this is the last, you get the last talk, Dr. Armstrong.
Oh my gosh,
last
okay.
talk of the meeting.
That's a tall order. So much like the previous talk, it's one of these be careful what you wish fors. I was looking around for a talk like this, and this actually happened about 2 or 3 weeks ago as well. So my worst tibial complication. So this case is fairly straightforward presentation of a patient with critical limb ischemia. He's a 74-year-old man with a non-healing wound of his right great toe. And consistent with that, his toe pressure was 20 millimeters of mercury, and his tibial pressures were also quite low with an AT pressure of 40 and an unobtainable posterior tibial pulse. He had actually been regularly attending podiatry visits, and the wound had been persistent for about 3 months by the time we found out about this, consistent with the fact that this had been a non-healing ischemic arterial ulceration. So we brought him to the cath lab, and this is the baseline femoral angiogram. You can see that the patient did not have any significant femoral popliteal disease. He did have some single vessel perineal runoff and occluded posterior tibial and an anterior tibial that was occluded in its proximal course. Distally, the majority of the reconstitution of the foot was through the distal anterior tibial proximal dorsalis pedis. You can see that otherwise there was some collateralization into the plantar branches, but very little flow, and certainly none in direct line flow to the area of the right great toe. So we felt, based on the findings of this from an anatomic perspective and the fact that this was a great toe lesion, was that revascularizing the angiosome and the anterior tibial would provide the patient with the greatest benefit. So I went down in fairly standard fashion, and this was actually a quite easy lesion to cross. Despite it being about a 250 millimeter CTO, I was able to go down with a Glidewire M 018 wire, which is one of my preferred initial CTO wires for infrapopliteal CTO crossing, and an 018 quick cross support catheter, and had the wire fairly straight with the tip for a while, looped it towards the distal end, and re-entered pretty easily. So you'll have to take my word for it, but there was no major funny business as far as getting the wire down in the first place, and crossed down here within just 5 minutes. So did a hand injection to verify that we were true lumen. Was pretty happy with this. Looked like it was going to be one of the easier limb salvage cases. So went in and started with some initial balloon angioplasty. This didn't appear to be a particularly calcified lesion, although I think you can appreciate that there's some calcification up here in the mid-anterior tibial. And did long segment balloon angioplasty, as is my usual standard approach. This is a 25-20 by 220 nano balloon. So it's a tapered balloon, 2 millimeters distally, 2.5 proximally. I like these for below knee interventions because I think that they can be very useful for long segment angioplasty. And this is a fairly conservative balloon angioplasty for the initial dilation. You can see that after that, there was some improved flow down the anterior tibial coming down with essentially straight line flow, but a fair amount of recoil in the proximal to mid segment. I think the initial balloon was fairly undersized. So I then went in with a subsequent balloon. This was a 3530 by 220 balloon. So this is the 3.5 portion, this is the mid segment, and then the more proximal half of the balloon, some of which is not shown here. But the balloon actually expanded pretty easily. I expanded this at 6 atmospheres for about 3 minutes to do kind of a long segment, prolonged balloon angioplasty, and was anticipating that this should result in a pretty good balloon angioplasty result, hopefully with minimal recoil and no significant flow limiting dissection. So this is the angiogram right after I did that. On DSA, you can see coming down, there's some good flow in the perineal. Unfortunately, although there's reasonable flow in the anterior tibial, you can see that the mid-anterior tibial does have an area of perforation. And I still honestly don't understand exactly why this happened. I think there was some moderate calcification in that region. I still don't think that the balloon that we used was particularly oversized. In retrospect, perhaps performing intravascular imaging might have helped explain why this was more likely to occur here, because in my experience, having done over 1,000 critical limb ischemia cases at this point, I've had 2 perforations. And the other perforation I had was related to complex retrograde access and reverse cart this was a fairly straightforward antegrade crossing. Any thoughts from the panel about what may have predisposed to this in the first place? Or just bad luck?
So tibial perforations, actually, I hear about a lot of them, and I have seen them with different people when they present their cases. And I think it's just the nature of the disease. First is one thing is the nature of the disease, the calcification is in the area. But other things I have also seen when people go down with the wires, right? Sometimes you have your wire exiting into these small branches, and if we are in a little rush and we don't control that, they can just perforate those small branches.
Yeah, that's certainly a possibility. And I mean, I used a glide wire M, which could certainly go into some small branches and poke into them. I guess what I would say is after the initial balloon angioplasty, there was no perforation. It was only after the subsequent angioplasty. I wonder if there was a calcified nodule in that area that then just resulted in perforation locally.
It's funny because, Ehrin, he wasn't in the area where this most severe residual disease was.
Exactly.
We're trying to fix the more proximal area.
Yeah.
He's more distal.
Yeah, the more proximal area looks pretty good now.
I wonder
actually.
if the edge of the balloon was there. Is it possible that the edge of the balloon was there? Maybe, I don't know. It was a long balloon.
It may be. It was a long balloon, and I think it ended just near that region, so that may have been partly just resulted in a tear. So, in this case, I think there's numerous potential options. One option would be to do continued prolonged balloon angioplasty and see if this resolves. Another would be to potentially add on a large blood pressure cuff, inflated suprasystolic pressures. The concern here clearly is to avoid compartment syndrome and continued perforation. So I did perform additional balloon angioplasty for about 8 minutes and then took a repeat angiogram, and there was continued perforation. So I decided that something else needed to be done at this point. And so what I did was, in order to minimize the amount of contrast going in, marked exactly where the perforation was with a hemostat. And my first approach was to just go ahead and put in a drug-eluting stent, because I thought that perhaps there was a flap that had been unroofed, and that if we put in a scaffold, then that might help prevent any further bleeding into the anterior compartment. So this marks putting in, I think it was a 2538 Xience drug-eluting stent. And this is what the angiogram looked like after that. So now you can see the flow is actually a little slower down the anterior tibial than it had been before. And that really didn't seem to help the continued perforation at this point. So at this point, I had more sluggish flow down the anterior tibial than I had before. I also had a continued perforation despite putting in a coronary drug-eluting stent to try to tamponade that down. And so my decision-making at this point was that I thought that closing this perforation was going to be important for the patient's outcome. I also wanted to try to maintain the patency of this vessel. An alternative might be, for example, to embolize it and just shut it down. So actually, off the shelf, I decided that I would create an IRB disaster and got a Graftmaster. So this is an 18 millimeter Graftmaster put in. You can see I put it in partly through the prior drug-eluting stent and a little proximal to that to really cover the area of the perforation at the inflow. And after doing that, actually, there was much, as you would expect, there was no evidence of continued perforation after the Graftmaster, which was placed just in this region here. And then there was some residual disease and some dissection distally, so I actually did put an additional stent distally as well. And this is the final result with minimal residual stenosis and good outflow down the anterior tibial. So the patient did well. He actually was not hemodynamically stable. He did not get any significant compartment syndrome and was able to go home the next day fairly easily. So tibial perforation is a rare complication of tibial angioplasty. As I mentioned, this is the second case I've seen in the years that I've been doing it. There are many cases can be treated with prolonged balloon inflation because small perforations will seal and resolve. The clinical concern, of course, is for compartment syndrome. That can occur in any of the lower extremity compartments. It is more common with peroneal access because it's a non-compressible site. The other major cause tends to be perforation in the mid-tibials because these are non-compressible sites in many cases. And there may be a lower likelihood with pedal access due to the retrograde access and self-tamponade of any perforation because you're advancing the wire from the other direction. As far as diagnosing compartment syndrome, I think it's important to have a very high index of suspicion. You can diagnose it with invasive measures at the bedside. This is an example of one of those devices. It's usually defined by compartment pressures more than 30 millimeters of mercury and needs to be treated with emergent surgical fasciotomies. I have had one case where a patient required a fasciotomy from compartment syndrome. That was my other tibial perforation. I just didn't have very good pictures to go with it. And what I would say is that the posterior compartment is very difficult to access, and you have to be very careful that the surgeon is looking at the correct compartment when making the measurements, because in that patient, I had the surgeon measure compartment syndromes at the bedside. He said everything looked okay, and then 2 hours later, the patient lost all ability to move their leg and had to get emergent fasciotomies. And I think in retrospect, it's because the posterior compartment can be a little bit more difficult to access. So with regards to Graft Masters, I think as cardiologists, we are familiar with these. These are covered balloon expandable stents. They're stainless steel and covered with PTFE. They do have an HDE for application for coronary artery or saphenous vein perforations with a vessel diameter greater than 2.75. There are newer versions out in the last 2 years that are RX and fit through a 6 French guide. The labeled diameters on the Graft Masters are 2.8, 3.5, 4.0, 4.5, and 4.8, and they can be post-dilated, my understanding, any of these up to 5.5 millimeters. However, the stent will foreshorten with post-dilation up to 25% if you're post-dilating it significantly above its reference diameter. The other thing I would point out is this is actually a picture of the box from the Graft Master I put in. It was a 2.8 by 19 millimeter. The 2.8 is actually the OD. So the 2.8, much like a Supera, is a measurement of the outside diameter of that stent. So if you're deploying a 2.8 Graft Master at nominal, the ID is 2.18. So that's important to consider as far as the vessel that you're treating. I also find this hard to believe, but somehow the nominal pressure is 15 and the rated burst pressure is 16, I guess suggesting that you should be careful when you inflate them. So thank you very much.
Ehrin, that was fantastic.
Quick question. Did you have to reverse the anticoagulation, and what are your thoughts about putting a pressure cuff proximal to the perforation?
Yeah, you know, I think in thinking about this case, I may have been able to get away with a more conservative approach involving a pressure cuff more proximally and giving protamine. My major concern was because the patient had pretty poor distal runoff, and this was a case of critical limb ischemia, I thought in that case I might be potentially committing him to a major amputation if I couldn't retain flow down the AT. But that might have been one approach, and then to try to bring him back perhaps a week later or so to try to open up the anterior tibial.
Any other questions?
Maddie, one question from you. Have you ever done coiling in lower extremities for these kinds of bleeds?
No, I have not done coiling, but I was just going to tell you about one of my cases. I had this case where I was trying to get proximal AT access, and I hit the vein. And typically, if I hit the vein, I hold pressure with my thumb for like a minute or two, and then I just go and hit the artery. And in this situation, we did that, and so we went for the artery. We treated the patient, and this was actually a case of claudication that we couldn't cross-integrate. And sent the patient upstairs. Everything was fine. The next morning, my fellow saw the patient, was going to discharge the patient, and does the paperwork. Patient is ready to go home, stands up, and just collapses. So we go to see him, and he's now all of a sudden has all this pain, severe pain, in his compartment, in the anterior compartment. And basically, to make the long story short, we realized that, there is something going on, in the calf area, at the site of the access. And it turned out that the patient had, so he went to surgery for fasciotomy. And it was a small fasciotomy, but what the surgeon described to me was that it wasn't a compartment, it was actually bleeding within the bundle. So the bundle of the nerve artery he said it was very, very small amount of blood. So it was a venous bleed. So I guess the teaching point is that those are actually sometimes a little bit worse in the sense that you can miss it. Because with the arterial, the patient within half an hour and a half, 2 hours, will start complaining of pain. But with venous, it can go a long time before the patient have the pain. So if you hit the vein, now I'm holding for 5 minutes. So I'm just some tip, if you ever hit the vein, and you're up in the calf, I would hold for 5-6 minutes, a couple of minutes longer.
Excellent point.
Yeah.
Well, I want to really, Mehdi and I would love to thank you on behalf of the directors of the course. Thank you so much for coming here for our inaugural year. I think this was a really fantastic turnout. I hope that these sessions were useful. I think examples of these complication sessions especially are, I'm going to take home how to make a covered balloon expandable stent, if that's ever necessary. I think you can always learn things here for cases that we hopefully hardly ever see, but from which you can learn a lot. So thanks again very much, and we look forward to having you back here next year.
Yeah, thank you very much.